imagine you are sitting in a children's park and the kids are playing, and what the kids are doing, they're basically cutting with scissors some pieces of sponge, and they're putting those pieces of sponge in a glass full of water. And when the pieces of sponge are there in the glass of water, and when they hold the glass upside down, no water is falling off the glass, because now the sponge basically hold or retain the water inside the glass. Similarly, inside our blood, there are certain proteins, plasma proteins are there, chiefly albumin, which tries to hold or retain the fluid inside the blood. And this pressure, which contributes to holding or retaining, contributed by the plasma protein, they are called oncotic pressure or colloidal osmotic pressure. And this pressure is one of the pressure which plays along with the hydrostatic or hydraulic pressure, the integrity of the blood vessel wall, and the integrity of the lymphatic channels to disperse the fluid which is accumulating in the interstitial fluid. These are the factors which play a crucial role in the development of edema. So this InstaLecture number 106 would be on the 5 mechanisms through which the edema develops. And I already introduced which are the key players in that. And I'm going to explain this in the whiteboard in a moment. But before that, I need to specify that there are two kinds of edema. One is called intracellular edema, another is called extracellular edema. But when usually the term edema is not specifically, we usually mean the extracellular edema. And in this section, I'm basically going to explain the mechanism of the development of the extracellular edema and also explain the approach to edema in a different section. So let us move to the whiteboard and we try to explain the idea that how edema develops. It's quite simple actually. So let me draw a capillary there. Suppose this is a capillary. And this side is the arterial side of the capillary. I am labeling it as A. And this side is the venous side of the capillary. I am marking it as V. Now, these capillaries are also like the blood vessels, they're lined by endothelial cells. And their integrity, of these endothelial cells are important because these capillaries actually normally are not leaky, but they sometimes become, there is increased vascular permeability occurs. They become increasingly leaky. That is also another important concept in understanding the edema, because in inflammation, usually there is a retraction of the endothelial cell occurs, so the fluid comes from inside of the outside of these capillaries and causing interstitial fluid accumulation. So firstly, and also there will be some cells here that I want to draw. These are the cells actually, and this is the interstitial space. And obviously there will be some lymphatic channels would be there actually to drain the fluid outside, afferent lymphatic channels. So normally what happens when the blood comes through these arterioles into this microcirculation of the capillary, in this arterial side, I can divide this into like imaginary line by this. This arterial side, usually the hydrostatic pressure means the pressure which basically wants the fluid to go outside of this capillary into the extracellular space, which is working on the outside. That is the hydraulic force or the hydrostatic force, both the same. This force is higher. And there is also another inward force which is acting, which is trying to keep the fluid inside the capillary. The force which I mentioned is the osmotic pressure. And this osmotic pressure is basically contributed by the plasma proteins which are there in the blood, chiefly by albumin. Now, normally in this arterial end or the arterial end of the capillary, because this is the arterial end and this is the venous end, as this is coming from the systemic circulation from the left ventricular side. So this side, the pressure is higher. So obviously this side, this hydrostatic force is higher. and the colloidal osmotic pressure is little bit lower compared to this. Usually 35, 25 in this. This one is 35, 20. This one is 25. The colloidal osmotic pressure. So some amount of fluid normally actually goes out here in this arterial end. But in the other side of the capillary, when this is coming to the venous side of the capillary, what is happening that this hydrostatic force, because now it is coming to the venous end, the pressure is coming lower. This side, the hydrostatic force becomes little bit lower compared to the capillary and the colloidal osmotic pressure. So the fluid actually, whatever has come out, they mostly get back inside the capillary. This is the idea. And if some fluids normally they remains in the interstitial place, they usually are drained out by these lymphatic channels, LC, the lymphatic channels. So normally, I'm again repeating what is happening, that in a microvasculature, in a capillary, usually from the arterioles, the fluid comes inside the capillary, and in the arterial side, as the hydrostatic force, which is working outside, this is the hydrostatic force, H, they are higher, some amount of fluid normally gets out. And again, when the venous out, the hydrostatic force becomes less, some amount of fluid also comes back again back to the capillary. And some amount of fluid still remains in this interstitial space, which usually gets drained by lymphatic channels. So normally we do not develop edema as such, because edema, extracellular edema basically means accumulation of the fluid in the tissues, particularly the extravascular tissues or extravascular space. Now, to develop edema, it can occur by 5 ways, 5 methods, which you need to understand. The 5 methods are this, that if the hydrostatic force, which is basically trying to get the fluid outside of the blood vessel, that become increased, the edema could occur. Secondly, edema could occur if the colloidal osmotic pressure, if your plasma protein level decreases, albumin level decreases, hypoalbuminemia occurs, like for example, some malnutrition patient or cirrhosis of the liver patient. Even in the nephrotic syndrome, it's one of the contributing factors, the hypoproteinemia or hypoalbuminemia, which usually develops in the edema. So in this condition, what can happen? Your colloidal osmotic pressure could decrease. Third thing which can contribute in the development of edema, if these endothelial cells which are there, these endothelial cells, they are retract. That means the space or gap is created between these endothelial cells, which typically occurs in the acute inflammation. Because if you know, remember that the key feature of acute inflammation is increased vascular permeability. That means the endothelial space cells, the space is created between them and fluid can come out. The fourth thing which contributes a important factor in the development of edema is the integrity of this lymphatic channel. If this lymphatic channel, actually there is a fibrosis is occurring in the lymphatics pathway, or there are removal of the lymphatics as well as the lymph nodes, which occur usually during the surgery, or usually some infection like Ucheridia bancrofti, which is a nematode infection actually caused by Ucheridia bancrofti Brugia malai, which ultimately results in filariasis. Usually this lymphatic channel could be blocked or fibrosed, and obviously the fluid cannot be drained via this lymphatic channel into the subclavian vein and again come back to the circulation. So if these things are not occurring, that could result in the edema. So if we summarize this, which I would like to write, let me clear all this thing for a while and try to write down that what are the causes of the development of the edema. So the development of edema could occur via 5 things. 1, increase in hydrostatic pressure, capillary hydrostatic pressure. It's also called hydraulic pressure. See, second, decrease in capillary oncotic pressure. Let me write, then I would again explain what are the ideas behind it. Third thing, blockage and obstruction in lymphatic drainage. Fourth thing, particularly important for the edema, very important actually. That is the increased vascular permeability. The 5 is retention of sodium and water. Now, each one I would like to explain one by one. So let me, in the side, let me draw again the microvasculature. So suppose this is a capillary. This is the arterial site, which I was drawing. And this is the venous site of the capillary. So this is the arterial site A, and this is the venous site. And there are cells there. This is the interstitial space. And obviously there are channels, lymphatic drainage system is there. If there is fluid, some fluid of accumulates in this interstitial space, they will be drained by this lymphatic channel, LC. And these capillaries, they're also lined by endothelial cells. So now come to the first is what can cause increase in the capillary hydrostatic pressure. Capillary hydrostatic pressure could increase if there is some kind of blockage in your venous return. Take for example, it could be due to in the congestive heart failure, because now basically what's happening from the left ventricle to the systemic circulation, it is coming to the artery, then coming to the arteriole. From the arteriole, they're coming to the capillaries, and the capillary from the venule again going back to the larger veins, ultimately to the right sided atrium to the heart. This is the way the circulation is moving. So if there is a blockage in the heart, that means there's a heart failure and the heart is not able to receive blood from the peripheral circulation. So obviously there will be obstruction in the venous drainage, because venous blood cannot move back to the right side of the atrium. So if they cannot move there, obviously the pressure inside, the pressure which is the hydrostatic pressure, hydraulic pressure, that can increase. And if that increases too much, obviously the fluid would come out from this capillary back to the circulation. And when they come back to the circulation, it's not circulation actually, the interstitial space. And in the interstitial space, so much amount of fluid could be accumulated that cannot be drained by the normal lymphatic drainage system. So obviously there will be fluid accumulation here in this interstitial space, and that could result in the edema. And as in conditions like congestive heart failure, it could occur in the whole body. This condition would be called anasarca. So this is the number one, where there is an increase in capillary hydrostatic pressure. Similarly, suppose there is in the deep vein of the lower leg, there is a thrombus formation has occurred there in this side, venous side. So obviously the fluid cannot move out through this venous circulation. So obviously there would be blockage, and this fluid, there would be rise in the hydrostatic pressure. That could also cause localized edema in that part. So obviously increase in capillary hydrostatic pressure can result in the formation of the edema. Second is decrease in the capillary oncotic pressure. Capillary oncotic pressure means, I told you already, that inside the capillary, inside the blood vessel, within the blood, there are a lot of plasma proteins are there, and plasma proteins just act like sponge. They basically hold or retain the fluid inside. So if their number, the number of the sponges, they have decreased in the blood, because if, for example, take an example of cirrhosis. Cirrhosis is really liver failure, so obviously there will be decrease in the on the formation of the plasma proteins, or there is increased leakage in certain conditions like nephrotic syndrome. Nephrotic syndrome also, there is a role of the retention of sodium and water, but also hypoproteinemia, hypoalbuminemia plays a role in the edema formation. So in nephrotic syndrome, when there is a leakage of this albumin, obviously the number of plasma proteins are decreased. It's equivalent that there's a less number of sponges there in the blood which can hold or retain the fluid. So obviously, as now there is the balance is disbalance, because now the conditions like hypoproteinemia, malnourishment, malnutrition, or protein losing gastroenteropathy, or cirrhosis, when there is no less formation of the protein, or usually conditions like nephrotic syndrome where there is a increased leakage of the albumin. So what is happening that this coloidal osmotic pressure or oncotic pressure, which is same thing actually, they are basically decreasing due to the lack of the number of the plasma proteins which are there. So as this force which basically holds the water, retain the fluid inside the blood vessel, that is decreasing, then the externally working this hydrostatic force that would take upper hand. So obviously in this condition also the fluid would come to the extravascular space and causing edema. But this edema would be due to decrease in capillary oncotic pressure. So we understood there is an increase in capillary hydrostatic pressure, there is a decrease in capillary oncotic pressure. These are the causes. Then some conditions like blockage and obstruction, like I talked about this lymphatic capillaries there. So normally some amount of fluid in every one of us, including us, they actually get accumulate in the interstitial space, interstitial fluid. But that usually promptly gets drained out by this lymphatic channel. So in certain conditions where your lymphatic channels are blocked or there is a fibrosis, for example, I mentioned a common condition like filariasis, which is caused by some parasites like Ucheridia bancropti or Bruguier malayi, or there are some conditions where there is a blockage or fibrosis of these lymphatic channels due to radiotherapy or due to some post-surgery, post-cancer surgery, or due to certain cancers could be there some blockage. So obviously, as this pathway to clear out this interstitial fluid is blocked, so in that condition, what would happen? Even some little amount of fluid which is accumulating, they cannot be drained out. So progressively with time, there could be more and more amount of accumulation of fluid in the interstitial space, and that could result in the edema formation. That is the number 3, the way the edema formation occurs. Now let us go and move to the mechanism number 4, increased vascular permeability. This is the cause of edema in the acute inflammation. I think in acute inflammation mechanism, you have read that there are 2 steps in the acute inflammation. One is vascular changes, another is cellular changes. And vascular changes, basically there are 2 steps occur. One is vasodilation and second is increased vascular permeability. So what is increased vascular permeability? It's basically a sophisticated jargon to say that the blood vessel is becoming very much leaky. So in acute inflammation, what occurs that this is a capillary and these capillaries are lined by endothelial cells. So now usually there is a gap created between the endothelial cells because endothelial cells retract. Retract means that creates a space between endothelial cells. The inter-endothelial cell gap is created. So through that gap, the fluid from the blood vessel, they can come out. Not only the fluid, also the protein and other things, they can come out from the blood vessel to the extravascular space. And this is known as increased vascular permeability. This is driven by a lot of cytokines and the chemical mediators of the acute inflammation. And this is necessary because in acute inflammation, what the body wants that the more amount of cellular constituents, particularly the fluid, which contain plasma protein and other things, they should move out of the blood vessel to the space where they want to neutralize the cause, the trigger for that acute inflammation. That is the reason this increased vascular permeability occurs. And basically, usually in that case, we can see like a lot of plasma proteins and other things are moving out. This is called exudative edema actually. A lot of exudates come out with a lot of proteins and other things. And if you compare, and when the fluid which comes out in other first 2 conditions, particularly increase in capillary hydrostatic pressure and decrease in capillary oncotic pressure, usually the fluid which is coming out, they do not contain much amount of protein or the other cellular constituents because this is called transferativity. The idea is very simple. In this case, in case of increased vascular permeability, the endothelial cells are retracting actually. So the gate is much more wide open. So a lot of things can come out easily from inside the blood vessel to outside of the blood vessel. That is not occurring in the 1 and 2. 1 and 2 is basically the interplay between the capillary hydrostatic pressure and the oncotic pressure. So you can imagine that if there is, if I keep this door wide open, anything can come out. It's like that. But if you just keep the door a little bit open, the door is not open, but usually due to the interplay between the pressure, capillary hydrostatic pressure or the oncotic pressure, the fluid is moving out. So obviously, not much amount of thing can come out with the fluid because there is not much space. But in this condition, what is happening? There is a space created between the capillaries, between the endothelial cells which are lining the capillaries. So obviously through this thing, all things can come out, including the cells, including the fluid and other things. This type of edema is caused by in acute inflammation. It is caused by increased vascular permeability. And fourthly, in renal failures, usually we see retention of sodium and water. So if you know that retention of sodium and water typically seen in renal failure that could develop cause in the development of the edema. And that also plays a role in the development of edema in conditions like nephrotic syndrome. So these are the 5 mechanisms through which the edema could occur. Increase in capillary hydrostatic pressure, that means the hydraulic force, the hydrostatic force, which is basically working in the capillary, which is wants the fluid to go outwards from the capillary to the extravascular space. When that is increased, particularly occurs due to some kind of problem or obstruction in the venous drainage. That means the conditions like congestive heart failure, where the venous drainage is impaired because the heart cannot receive actually congestive heart failure the right side of the heart from the venous circulation, because the heart is dysfunctional. In that condition, what would happen? The pressure in the microcirculation would increase, the hydrostatic pressure, hydraulic force, and this hemodynamic force, when they increase, that would cause the fluid to come out of the capillary into the circulation, outside of the circulation. That is called increase in capillary hydrostatic pressure. Second, I mentioned that there is the concept called oncotic pressure, which is basically contributed by the plasma proteins, particularly the albumin. And this plasma protein act like a sponge, and this sponge hold the water, hold the fluid inside the capillary. Just like in the beginning, I give you an example that when the kids are playing and they're cutting the sponge and putting into a glass full of water. So normally, if you make a glass full of water upside down, the water will fall. But if you put down all those sponges, put all those sponges in the glass, and the sponge hold the water, if you now do it like this way, no water will fall, because now the water is retained by those sponges actually. So similarly, normally what is happening in our blood, the plasma proteins are holding or retaining the water. They try to keep the water inside the blood vessel. So the force is working inside. They don't want, they're working in opposition of the hydrostatic force. The hydrostatic force want to keep the water outside of the blood vessel, but this plasma coloidal oncotic pressure, they want the water keep inside this. So when this, and normally they're in a balance. So when this force is disbalanced, particularly the conditions where the plasma colloidal osmotic pressure is decreased, like when in those conditions where there is a hypoproteinemia or hypoalbuminemia, because the number of sponges or the plasma proteins are less, that could result in the development of the edema. So what conditions could lead to development of decreased colloidal osmotic pressure? Any condition where the plasma proteins, particularly albumin, is decreased. Hypoalbuminemia could occur in conditions like nephrotic syndrome. It could occur in cirrhosis of the liver, because obviously the liver is not synthesizing adequate amount of albumin, or conditions like malnutrition, malnourishment, and malnutrition, particularly, better to say. And obviously protein losing gastroenteropathy. These are the conditions where you see them. Blockage and obstruction. Third mechanism is blockage and obstruction in the lymphatic drainage, which I mentioned that ultimately in every one of us, some amount of fluid gets accumulated in the interstitial space. Because as I told you that there is usually in the arterial slide, some amount of fluid comes out, then some amount of fluid in the venous side of the capillary that goes back, but still some amount of fluid remains in the interstitial space, and that is usually drained by lymphatic channels. If the lymphatic channels are blocked or obstructed, usually in conditions like infections like filariasis or radiation therapy or post-cancer, some surgery or post-cancer is lymphatic spread, that usually can causes the lymphatic obstruction and causes impairment in the drainage of this amount of fluid which is accumulating in the interstitial space and normally gets drained out. And also I mentioned about the retention of sodium, and the fourth point, retention of sodium water, which is in the renal failure. And another concept which is very important, particularly also we learn about it in the acute inflammation, that is increased vascular permeability. Normally a capillary, including all blood vessels, is lined by the endothelial cells, and usually this cell is intact. Now in acute inflammation, what happens, these endothelial cells retract from each other, creating a gap or space between endothelial cell, so that the fluid can come out from the inside of the blood vessel to the outside of blood vessel. And that also causes edema in the inflammation, acute inflammation particularly. That's why acute inflammation usually we see that whatever area is acutely inflamed, that areas get swollen, because a lot of fluid comes out of the blood vessel into the extravascular space due to the increased vascular permeability, which I already mentioned. So in a nutshell, what we learned today, that what are the key mechanisms of edema. And edema means I'm talking about extracellular edema, because there is also concept of intercellular edema. And I mentioned that there are 5 things which play a role. One is, I mentioned, is the increased hydrostatic pressure. Second, decreased colloidal osmotic pressure. I also explained the concept of the colloidal osmotic pressure. Third is obstruction in the drainage of the lymphatic system. Fourth is increased vascular permeability. That means the capillaries of the blood vessels become very leaky, which is a key feature of acute inflammation. And fifth is the sodium and water retention, usually seen in the renal failure conditions. So that's all the concept of the causes of the edema in a nutshell. In a separate session, I'm looking forward to discuss about the to approach in a patient of edema, having edema, how to approach that. So thank you very much. Have a nice weekend.